Dr. Somshila Ramamurthy, Dr. Gaurav Luthra, Dr. Chi Sun Fek, Dr. Minu Mathan, and we have you as the audience and you to ask questions. We will devote time to the question answers, and I'm sure that you would like to take this up. We have a keynote address, and that we'll take up first because Dr. Mohammed Madi has to go to another hall, and it's on management of ruptured posterior capsule during phaco. So please welcome Dr. Madi.
First of all,
why don't you come to the front rows, please, so good interaction can take place. Why don't you come, ma'am? Can you all come to the front rows so that we can do a good interaction?
Thank you very much, Mr. President, for inviting me for this nice meeting. Okay. Okay, I would like to present here is that phaco nightmare, which is with ruptured posterior capsule during phaco, which is a very bad complication that can be met for everyone. But what I'm trying to do is how to escape going into this bad complication. Capsular problems and vitreous loss are inevitable. Even the best surgeon could have it. And so the challenge in cataract surgery is to minimize the risk of complication and optimally manage complications that do occur. In order to do that and to prevent this complication, you have to be ready before starting any case and early recognize the complication, respond early, and then go to the actual management as you planned. In order, if you have a big list of these complicated cases, you should be ready before starting such cases. Because every case, you should prepare a mental flow chart and maneuvers and sequence of decision before entering the patient eye in such a cases. Because each eye needs some sort of mental flow chart to how to deal with it. I will prepare surgeon, anticipate potential problem cases, and keep the required instruments on standby. Of course, prevention is very important, and we should realize that each step of cataract surgery is built on a solid foundation of prior maneuvers, early recognition. The index of suspicion of the surgeon should be very high in order to detect the bouncing of the iris diaphragm or changing in the anterior chamber depth or changing in the pupil size, or which might indicate break in the posterior capsule. Also, there's a reliable sign of vitreous is present if there is loss of flowability of the material and phaco efficiency during phaco or irrigation aspiration, because vitreous cannot be phacoed. It can only be cut. Early recognition is very important. Ominous sign of impending loss of material into the posterior segment is deepening of the anterior chamber and rotation of the nucleus. In the early response that we have, we should control our innate withdrawal response and on recognition of the problem, and go to foot pedal position 0, and don't remove anything from inside the eye, and inject viscoelastic, ideally dispersive, between the posterior capsule and the remaining lens fragment till the anterior chamber is normal depth. Then remove the phaco tab and go. Now, while you are relaxed, it's time to assess the situation, inspect, relax, and think what are you going to do, and announce the situation for the staff in the OT room, and the vitrector machine should be seamlessly ready in the room. This is a kind of vitrectomy kit that should be available in every room in order not to lose time while the eye is opened. And the actual management plan will start later on with augmentation of anesthesia if you need, damage control, compartmentalization of the anterior segment, manage the prolapsed vitreous with vitrectomy, remove the remaining nucleus, and manage the posterior dislocated or dropped nucleus or lens fragment, as you can see. Here I'm going to show a few cases. The first case would do while doing phaco. I am finished with this case. I noted superiorly here that I went deeper little bit, that's so that I suspect they injured the posterior capsule superiorly by some glow is shining here, as you could see here, and will appear later on. I put in my mind that something wrong happened. That's why I decreased the fluidics and did nuclear disassembly in situ. I removed the nucleus. Then after removal of the nuclear material, I reassess the case for the place of the suspected tear, as you could see here, which will be more apparent, in order not to enlarge it and to keep the vitreous posteriorly as much as we can. Then while doing irrigation aspiration and cortical cleanup, I should start cleaning up the cortex away from the area of suspected tear or the presence of the tear. Then I always refill with viscoelastic, as you could see here, and here is the tear is apparent here superiorly. It is not enlarging yet, and I'm keeping the vitreous posteriorly. No vitreous prolapse happened yet. Then I use the white bore cannula as the one of the viscoelastic, the methyl cellulose, in order to do dry aspiration without introduction of vitrectomy here. Then I injected the lens in the bag without any vitrectomy. The next case is, I noticed a BCRent, one of the junior staff was doing surgery, as you could see here, that the eye is tilted and the visualization is not that much good. Something happened with him, posterior capsule ruptured, and one of the lens fragments displaced in the anterior vitreous. I had been called, then I went, then I refilled the eye with viscoelastic, removed the remaining cortical material, and the compartmentalizing the anterior segment not to allow for vitreous prolapse, keep everything as it is without enlarging the posterior hole. Then, while injecting the viscoelastic, I should inject it inside the fornices of the lens away from the hole to tamponade the vitreous. Then I injected the single piece lens in the bag, just landed on the capsular bag without rotation, as you can see here. Then, after inserting the lens without that much dialing, I went with the irrigation aspiration, removed the remaining cortex. Then I went with the vitrector behind the lens and removed this displaced fragment, as you could see here. Here is the vitrector. Then I went to this displaced fragment and removed it, and the case is finished. The other case is during phaco here. Always if I'm suspecting that the pupil is not that much dilating and the capsular texture is not that good, or failure of good hydrodissection, I always suspect that something is happening, and I keep the fluidics as slow as I can. Then I did nuclear disassembly in situ here without nuclear rotation. Then the epinucleus and the cortex were sticky, and the cortex was not hydrodissected. I always use the handpiece to remove the cortex and the epinucleus, and also I removed this sticky epinucleus, but I was just that arrogant enough to injure the posterior capsule myself, so it is a man-made mistake here. In order to remove this sticky material of the epinucleus, the posterior capsule ruptured here. Then I start to do vitrectomy. There's two basic things in the anterior vitrectomy. If you want to cut the vitreous, you have to use the cut aspirate mode. And in order to remove the remaining epinucleus or cortex, you have to use aspirate cut mode in the vitrectomy machine, as I'm doing here. Cut aspirate to clear out the vitreous. Then I convert it to aspirate cut in order to engage the epinucleus and not to allow it to fall posteriorly. Then I removed it completely and inserted as you could see here, very slowly without allowing it to go back. Then when it's finished, I inserted the multi-piece foldable IOL. And the last case, I think I have to present this one, if you could allow me. Rupture posterior capsule before nuclear removal was managed with anterior levitation. Here, there's failure of good hydrodissection. Nuclear rotation was not good. While I'm doing trenching, there was difficulty in separation of the heminuclei. And while I'm trying to aspirate to engage the nucleus, I noted that anterior vitreous prolapse happened. This means that there's a big posterior rupture happened here. Here I kept the anterior chamber stable. I injected viscoelastic behind the lens material and elevated it anteriorly, and I used the cannula tab as a lever just to levitate it anteriorly. Then I removed it with the phaco here till the case is completed. And I always use viscoelastic during this maneuver in order to tamponade the vitreous posteriorly. And when I finished with the removal of the nuclear material and the cortex, I did anterior vitrectomy, then explored how is the integrity of the anterior capsule in order to prepare the eye for insertion of the lens. Here is the last piece of the nuclear material, removed with the phaco. Then I injected triamcinolone, anterior vitrectomy, then exploring the lens, anterior capsule with the Coughlin hook to be sure that only the posterior capsule is damaged. So there was no single piece or three piece there. I inserted hard IOL on the capsular bag anteriorly. And thank you very much for your kind attention.
Thank you very much, Professor Mahdi. And Professor Mahdi is a regular faculty in India. Thank you very much for your time. And if any of you wish to visit Egypt, he is always there to welcome you. And the Egyptian Society has a very good scientific program, and Professor Mahdi is one of the leaders in the scientific program. So write to Professor Mahdi, and I'm sure he's going to involve you in the program. Thank you very much. So we now go on to our horror show. And Professor Mahdi, you'll have to listen to all the horror shows because, you know, the last part, I'm going to duplicate on the PC ruptures. So you'll have to sit through the whole. Yes. So I'll ask Dr. Somshila Murthy, who has to go to another session, to speak about distressed cornea and cataract. Dr. Somshila Murthy is one of the best cornea surgeons in India, and she's in Mumbai. And at Shantilal, you'll have to...
Shantilal
it's a long one.
Sangvi Eye Institute.
SSLT,
yeah. Right? SSEI. So
yeah.
Thank you very much, Dr. Biswas. And I feel a little apologetic because he says she's a good surgeon and so on, so you can decide. And also apologize to Dr. Bhattacharya because we haven't used it. I'm sure you'll say that, oh, you should have used the BHEX ring. No, I do use it. We have some logistic issue and financial constraints, so sometimes we don't use it. But maybe
financial constraint, I don't accept.
Earlier, but maybe in these cases, maybe it was the iris hooks worked well. So I'm going to go through that. What is the mystery? I didn't use any hooks or expander in the first case, but it was a very interesting case. This lady had POAG since a long time, open-angle glaucoma, primary open-angle glaucoma since a long time. And she had some unknown reason for the corneal opacification. She couldn't follow up during COVID, and before COVID, the corneal opacification was much less, but when she came, she had advanced cataract and poor vision. So we planned for a right eye phaco, if possible, with a hydrophobic IOL. And then, as per the postoperative result, we decided to plan a transplant if required. So this was a surgical field that I had with me. Though it looks worse, actually, but on table, she had a very good red glow. and we could really see the center part. So what I did first is to only work in the central zone that I had, the central clear zone. So I did a very careful trenching, and everything goes on only in the central zone. Then after the careful trench, quite a soft cataract, then separated the two segments on the side. Again, kept on bringing, kept fracturing them into smaller pieces and kept bringing them to the safe area, to the center, and then gently aspirating them. And also I had to make sure that I am watching where the particles are going, where the lens fragments are, because sometimes you'll have residual fragments in the anterior chamber after the case. So I kept on all the time watching. So the tips here are that, well, one more problem I encountered was the iris kept popping out because this is an area which is very thin in the periphery. So after a short while, I made a new side port for me to put my side port second instrument. And then I use a lot of viscoelastic, and this is the epinuclear part, which, as you saw in the previous case, that is very dangerous to work with the phaco probe with the epinucleus if you can't watch what's happening. So here I kept on dialing the thinner fragments with the help of my second instrument into the visual area. And you can see once most of the nucleus is out, you see a very good red glow, and it gets better and better. So this was my surgical view. It was not as bad as somehow it's seeing in the video. And then very careful bimanual cortical aspiration. It looks a little okay, but it was not a walk in the park. It was like a spine-chilling kind of surgery where you don't know what's happening sometimes. So in this case also, I had a good rhexis. I had fairly good view. I could tilt the eyeball and make sure that I had not fractured the rhexis anywhere. And under a lot of viscoelastic, I carefully implanted the lens and ensuring that it's completely in the bag with its haptics to being completely in the bag, and then I could wash out the viscoelastic. So this, and then I sutured that side port because the cornea was very thin, it would not hydrate. So that's another tip, that we must suture these side ports. So in this case, the patient did well. Her vision improved to 20/50, although she did have field damage. So my reasoning was that even if we do a transplant, we might improve her field a little bit, but with good visual result post-phaco, I did not go ahead with a corneal transplant for her. So she did well even in the other eye. Coming to my second case, so these are the very challenging cases with really bad corneas. And it's a case of Stevens-Johnson syndrome with its sequelae. It's a one-eyed patient, and the eye that was affected was this one. So we had planned for an SICS because it was a total cataract and there were posterior synechiae. In fact, even the speculum went in with great difficulty because she had the eye was really closed down. And after trying to improve the ocular surface, luckily she didn't have a completely dry eye. She had some amount of wetting. We went ahead and did the surgery. My colleague, Dr. Supriya, took up this case. So this is, if those of you are familiar with SICS and are very good SICS surgeons, that's the surgery to go for these patients. So I used blue. We stained the anterior capsule with blue and gently separated out the synechia. And after that, we could achieve a fairly good rhexis, a large rhexis. And then this is again sort of just gently massaging the nucleus to come into the anterior chamber. We created an SICS tunnel and gently look at the cataract, it's quite hard also. And after that, we did a very careful cortical aspiration, and we left this patient aphakic because we were planning to fit a mini scleral contact lens for this patient. So it didn't really, this patient we implanted a lens, I'm sorry. But that was another option, that if we wouldn't be able to see enough, we would leave the patient aphakic. And she was fitted in with a mini scleral contact lens post-operatively, and all her other medications for SJS continued. So we could suture this well, and we managed to get a fairly good result of about 20/100 or something like that, so navigable vision for this patient. My case 3 is a patient with, this is the last case, with fungal keratitis. And the keratitis resolved with a dense corneal scar. Again, planned to do the phaco first, and then decide if we need a transplant later based on the visual acuity. And so for this case, I used the iris hooks, which is what I was apologizing for. And I just wanted the pupil to be dilated on this side, so I could see what I'm operating upon. So there is a posterior synechia here, which I go on to release. I am just placing the side port right there, so it's easy for me. So I like using these hooks also, apart from using the BX ring. So this was to cut the adhesions. There were a lot of adhesions between the scar and the iris. So that's what the micro scissors was for. And then careful rhexis. So I was very particular to ensure a complete rhexis. And then it was a soft cataract because a fairly young patient. I thought that it would not be a problem and I would be able to implant the lens. But the problem did happen, and it happened during IA, where while everything was going very well, and then I yanked the bag itself. So that was trouble number one, and then I filled in viscoelastic, and I decided to go ahead with my planned lens for this patient because I thought I'm going to do an in-the-bag fixation. But unfortunately, as I kept dialing the lens, it was not stable. And then the story started. It was like the horror show. So the horror show was that, first of all, I thought I'll put a CTR, then I put a CTR, then I removed the CTR. This is what happens because the bag just was not stabilizing even with the CTR. Then finally, after removing the CTR, I decided now, because the bag is not stable, I'm going to now remove the lens, which otherwise I don't want it to sink posteriorly and make my retina colleagues happy. So extended the incision just a little bit because you can pull this lens out very easily. And this lens, by the time he was panicking, would not come out. And finally, with you can close your eyes if you don't like such horror shows. Finally, I could manage to get the lens out in one piece. After that, I calmed down a little bit. I knew there's vitreous, and then went ahead and did an anterior vitrectomy. And finally, luckily, it's good to be very well versed. So I really like doing the iris claw IOL because it's so easy to do. It's just literally a 3-step. You have to make sure your side ports are just 180 degrees apart. You hold the lens with this particular forceps and go and enclavate the lens from both sides, from the right and from my left side as well. And this lens is rock stable. Nothing goes wrong if you enclavated it well. So this patient was very happy with post-op vision, didn't know the horror story that went on intraoperatively, and I didn't have to do a keratoplasty for this patient. So I'm going to end here with this is my team at the new place, which you couldn't pronounce. It's called Shantilal Sanghvi Eye Institute in Mumbai. I worked about a quarter of a century in LV Prasad Eye Institute, including my training, and now I'm heading this new center and trying to build it like LV Prasad Eye Institute. Thank you very much for this opportunity.
Thank you very much, Somshila, and we are going to remember Shantilal Sanghvi next time. Dr. Somshila is a really gifted surgeon, both cataract, cornea, and refractive. So any quick questions that we have for Somshila, can we ask? Anybody from the floor? First, we give a chance for the floor to ask questions on these. So if there are no hands coming up, I'll ask Somshila. These ones with the corneal opacities, and especially the vascularized corneal opacities,
Yes.
obviously they don't do very well with the grafts. And that is the reason why whatever vision that we can give for them
Yes.
should be given to them if the cataract can allow a little better vision, so
Yes.
that the vision from whatever it is can come up by 2 steps at least.
Yeah.
So the other thing is staining the capsule. I think it is a very important step in these cases, especially because you have to turn the globe to see that the rexis is going to an extent where it does not run off, and yet you don't have too small a rexis.
Right.
So the rexis part is the most important,
Absolutely.
I feel. And the other thing is, of course, your first case was amazing. I mean, getting all those fragments into the place and then taking them out. But again, the IA can become quite tough.
Right.
And here I think the irrigation aspiration, the bimanual irrigation aspiration is a better way of doing it
Yes.
than the coaxial.
Yeah. Right. Yeah. You're absolutely right.
Would a light pipe help in this case, the corneal opacity?
Yeah, that was also there on standby, but I had enough view, so I didn't really use it. I would have used it just to make sure that I had no pieces lying in the anterior chamber, but I was fairly confident. But that's always there for all our such cases. We keep a light pipe, an endo illuminator from the retina surgeons, but we don't steal theirs. They get very annoyed. So instead, we have bought our own. It's a low cost from APA makes it for about a lakh plus. So for if you have a lot of such cases, it's worthwhile not to steal the retina guys' instruments, but keep your own.
Yeah, a light pipe, I think we definitely should keep in the armamentarium, and it is a very useful tool because it actually lights up very well, and you can do a lot of maneuvers with that amount of illumination,
Yes.
which the direct illumination will not allow. And the red glow is very poor in such cases most of the time. Yes, sir. Yeah.
Take the floor mic, take the floor mic.
You can come to the floor,
Yeah,
Mike.
can-
Yeah.
There's one behind, there's one in front.
Up, bolo? Yes.
it could help to, if you have the adherent leucoma, for example, and also it can map out the corneal thickness. In certain areas, you know that the cornea can be extremely thin over there. So we have to make sure that we don't have any undue sudden increased pressure. So in cases where there is something like a desmetocele, to see the strength of that, so we might do an OCT, so that is helpful. So I think that for such difficult cases, if you have these equipment available with you, make best use of all that you have. So throw in everything for these to get the best results for these cases. I have
Yes,
a
sir.
question for Suvin actually, but yeah, maybe after.
Yeah, let's ask him first.
So, ma'am, considering that you can also do, you can suture the bag, IOL and CTR complex,
Yes,
versus doing an iris claw in this case. So, considering you could also do that versus an iris claw, what would you choose if you were to do that again?
So ever since I've shifted to iris claw, which I did during COVID time, very late of late only, I have not looked back, because as a corneal surgeon also for our endothelial keratoplasty and the post-operative results of these patients, I think that I've not had reason to be unhappy with iris claw. I've completely stopped doing bag suturing and Sionis ring or anything of that sort. So it's like a no-brainer for me.
So you don't encounter much inflammation?
I don't actually, and I'm a uveitis person, so I'm more cognizant of uveal inflammation, in fact, so I'm very happy with it. My only question to Suvin was whether he would have used the BX ring in any of these cases.
No, actually I won't have. I won't have. In fact, I'll show you in my own presentation case with iris hooks. So there is a place for iris hooks. This was one of those. Subluxated cataracts is definitely a very shallow AC, though BX is very thin. A very shallow AC, I think it's much easier to go in with iris hooks. So despite my financial interest in BX, I do use iris hooks once in a while. Yeah.
That's being so honest. Thank you, Shivan, for that.
Yeah, thank you. So thank you, Partho, for this kind invitation. So let's get on with the horror show. Like Partho said, if you had your lunch, good. If you haven't, hold it. Okay, so watch this carefully.
Dr. Minu?
Slide advance nahi ho raha hai bhai. हाँ, ठीक है. So watch very carefully, very carefully. Enough horror. I have your attention now. Anybody feeling sleepy?
Nobody.
Thank you. Take worth my effort then. Okay, so what I wanted you to watch was not or listen to it. You should have seen my two instruments. The phaco probe and the chopper did not move despite the nucleus dropping. So what we learn is we are in a land of ascetics. Be calm and composed even when faced with horrors like this. Okay? So assessment planning, enough of theory over here, consumables, technology. I'll show you some of that technology. Technique is important. And what is required in hard cataracts is patience, patience, and more patience. A little big basics. So that's the horizontal chop, where your chopper is at the equator. That's your vertical chop, where the chopper is right close to your phaco probe and goes only partial depth, and the chop propagates. And a little bit away from the phaco probe would become diagonal, but it's technically a vertical chop. Watch this. How does a vertical chop work? I mean, we shouldn't have horror only. We should have some learning also out of this. Can I have the volume, please? Yeah. If you have any doubts about vertical chop, this is your place to learn. I'm not going to scare you. Those are all vertical chops. The chopper only goes partial depth. Thank you. The chopper goes partial depth. The chop propagates to the floor. Okay, that's vertical chop. So let's watch vertical chop. This is actually a diagonal chop. The chopper is away from the phaco tip, and there The chopper is only going partial depth, and the chop propagates to the floor and the base plate. Okay, so you'll see a lot of this in all our surgeries, all the hard cataracts. That is horrific. Definitely, every hard cataract takes away a few seconds of your life, like it or not. And we are. So this is. I wanted to show you a vertical chop. You must remember that we do not want to go to the entire depth of the nucleus, and you do not need to. The chop propagates. Now let's look at a vertical chop. So this is a vertical chop, a real vertical chop. You'll feel that give over there. Tuck. That is the give. That's when you know that chop has propagated. So there is a lot of science and technology over here. So if you're going to do hard cataracts, we do need to adopt vertical chop into our practice. Otherwise, there will be a lot of phaco energy being used and a lot of collateral damage. This is a real hard one. I want to show what difference red glow makes. This is OmniGlow off, no financial interest, and the OmniGlow on at 100%. And despite that, I really don't have much of a glow. And this is a real hard one. But you look how technique and technology help us. We need to do very little hydrodissection, just enough to have the nucleus rotate. Actually, once you have a few passes of that trenching, the nucleus anyway gets a little loose and it can rotate. So you don't have to be very aggressive about that. And then we begin with our chopping. That's a real tough one, but you see that chop propagates till the floor. These are all diagonals because I really did not want to take chances over here. I can do a classic vertical chop, but then the balance has to be very fine, and you might actually damage the zonules also sometimes. So we need to be careful of that aspect. If I could just go through a little faster over here. Yeah, so you can see from that nuclear fragments that it's pretty hard. I'm sure all of you are good surgeons and you do face cataracts like this. We'll come to the horror show. The next one is definitely a little bit of a horror show. So here this went off well, and the lens in the bag, pretty satisfying. When should the CTR be placed? Like I said, I do use iris hooks. This is actually before I invented the BHEX. So watch this. I've done my capsular. I've got 2 minutes here. So a little bit of hydrodissection, and I try to rotate the nucleus. Now that's the entire bag and a very hard nucleus moving. Not a very happy scenario. Had to do this. This is a very old lady. So I also sometimes use a technique where I progressively go deeper. If I don't get my vertical chop correct, I can progressively just hold and keep grabbing the nucleus and going deeper and deeper with the chopper. Yes, barely managed to get the 2 heminuclei fragments. Now begins my trouble, as I can see that equator, you can see at the 6 o'clock that equator of the bag is coming. It's just popping up and showing its face. I don't like it one bit. There's a little bit of wisp of cortex over there, but most of it is the equator of the bag. It's not happy. Let's put a little bit of viscoelastic and inflate the bag. I was in 2 minds whether to put a CTR now, wait for the nucleus to drop. Options. So I used to be a VR surgeon in those days. I've hung up my boots now, like Partho. So you can see that equator of the bag. Now at this point I decided, no, I will not put a CTR. Let's try my luck, and that heminucleus can be used as a temporary equatorial support. Rotated that heminucleus so that I had supported the bag just to inflate the equator of the bag at that part. And let's try doing this phaco. If it sinks, we'll handle it, but if we get away, it's a gamble. And get away we did. But the bag kept coming. It was a very fine balance, and this is pre my BHEX, so that means we didn't have great machines also at that time. In fact, this went for the ESCRS challenging cases, I think, sometime in 2012 or something, or much earlier. I'm trying to repeatedly inflate the bag, and I'm nearly done, yeah. So then we decided to put a CTR. And here we are threading the CTR. I kept that nucleus over there, and I said, okay, now let's get that CTR in place. We had got that heminucleus also divided into 2 quadrants, so I had enough. I could now safely put the CTR and preserve the bag. Thread the CTR. You've got to be very careful because these bags can be a little fragile also, and we've had situations where CTRs have gone through also. So let's just advance it a little. Put the CTR and, I'm sorry, yeah. And then we managed to phaco the nucleus, and to my satisfaction, we did have a good capsular access, an intact bag, which allowed me to put in a three-piece multi-piece lens, which is not available now. I don't know if some of the older guys will know this was by Abbott. Clariflex, I think this was called. We don't have it now. So silicone lens. Yeah, so it was in the bag, and that's it. Thank you very much for your kind attention. I'll be happy to answer any questions later.
So thank you, Shivan. I think you really made all of us sit up, and I'm sure nobody can sleep now. But any questions to Shivan quickly? Yes, yes, sir. Can you introduce yourself and? Yeah.
So I'm Dr. Vansh. My question is,
Sure.
as per conventional teaching, what I have learned is you put in a CTR as early as possible. Is that correct, sir?
As early as you need, and as
early
early as
need.
you can.
Yeah. Okay.
So the two are very subjective. So it's a hard cataract. You need to create space for the CTR. Okay, so how you do it, at what point you do it, after removing a quadrant, injecting doing a little hydro, because if the bag is full and you put in a CTR, there's a wonderful paper by Aiki Ahmed and colleagues where the amount of zonular loss or damage because of insertion of the CTR is also there. It's a soft cataract. You have the cortical cushion. So your CTR, you can thread it through without any zonular damage. In a case like this, where I already know that my zonules are damaged and it's a hard cataract, I would like to play it, probably use temporary supports, capsular hooks or something like that. So it's a play. So it's a very diplomatic statement, you see.
Okay. Yes. And the second question being, could you have avoided the difficulty by converting it into an SICS the moment you saw that the capsule, that there was zonular loss? If you converted it into a manual SICS,
Then I won't be able to present it here today.
I think jokes apart, SICS is a very good bailout, very, very good bailout. And this is something that we tell our residents that please learn SICS well as ECC IOL, because these are bailout situations where you can, without compromising the cornea or any other structure, in such difficult cases, you can put in a lens even in the bag and it can be done. So SICS, ECC, IOL are not redundant. Any other questions we have? Okay, so we have another stalwart. He is a teacher and a magnificent teacher. He has rolled out resident batches after residents, and he is going to tell us about the IOL dislocations. So when you have a subluxated bag, you have done a good job and you think you are done well, and finally you see that the IOL is out of place, what do you do? Minu Mathan.
Thank you, sir. Good afternoon, ladies and gentlemen. Thank you for this opportunity, Partha, sir. SICS, as he said, if we know SICS well, it's a good bailout. So as he said, underline the point, learn SICS well. Don't have, partially done few cases and this at this stage, I'll just do SICS and take it out, won't work. Okay, and some IOL dislocations, no financial interest in this. My resident, as he said, doing this case with a PC rent here. Aspirating vitreous nicely. I told her, place it into the anterior chamber, we'll place it. But invariably, even if you want to place it in the anterior chamber, most of these lenses will directly go into that area. I told her, get a forceps and hold it. She's trying to see the hands shaking and all those, and then again asking nurse, where is the forceps? By that time, it says bye-bye and it is gone. So, remember, if there is a large rent and if you want to place it somewhere where you want to, place it in the anterior chamber, fix up, and then gently place it where you want to place it. So, this is the problem. Adrenaline, when it comes, you don't know. So, this is a 20-year-old surgery, younger person, traumatic cataract, decentered IOL. And you see, this is an open area here. And this lens is a large lens but still decentered. See the deformed haptics. So I find that this opening is there, so I do a vitrectomy and then cut open this opening. The rest of the bag is fine. Inferiorly there definitely must be zonular loss. That must be the reason for this one. So I was scared if I cut too much of this fibrosis, the bag may just give way. So I just nicked this area, made it larger, placed a 13 millimeter three-piece lens there, and saw that how to optic capture this. See, then it was not so very large enough to optic capture. So I took my bold decision to cut the fibrosis, but nothing happened. So if you have your cut ray slightly lower and then munch it very well, you can cut these ones and then see the way I can posterior capture on this, so it easily goes in. There is no extension at all, and it is snugly fit. So these things, if you release, it is all going to be messy, and you have to release the whole thing. See the pupil constricted, and the P1 and P2 are overlapping, and it is fairly well centered in the bag. And so minimal manipulation. Yeah, next one. Minimal manipulation will be the best deal. Again, a decentered IOL for some time. Patient is complaining of glare. So why is it so? Constricted the pupil, see the iris which is retracted to one side, fibrosis here. So that edge is coming in the pupillary area, and that is causing his problem. So, but if you keep the eye straight, the Purkinje images are on the optic. So I decided to correct this by minimal, I'm talking about minimal manipulations or for these kind of problems which can get you through. So you do a pupilloplasty here and bring down the pupil and open this side of the pupil a little more, and then this IOL is still in the visual axis in the pupillary area, and the pupil becomes smaller, and make sure that your Purkinje image is still in the center of the pupil. If that is so, you can get away with this, and patient did not have, he had 6/6 vision. Only problem was his glare because of the iris being retracted to one side and the slight decentration of the IOL. So this is the 4th row pupilloplasty, 9O or 10O Prolene, 4 rows on this loop, 2 bites on the iris here, and then retract this. 1 knot is enough. 4 knots, 1 knot is enough. You don't have to retract back, again 2, 1, 1, and all those, not required. So if it becomes too small and you want a little more of the pupil, you can extend by doing a little vitrectomy on the pupillary margin or a sphincter cut with your scissors. So this is his case. He had such a large dialysis and CTR, and patient came back to me after 1 year like this, you know. So if they are so loose, it will be like this. After them, they'll come back to you, or one of you can send them to one of your enemies. Yeah? So anyway, I open up the pupil, very important, visualization, and then viscote above and viscote below. There is a CTR, there is an IOL. So this is just floating in the AVF. So now I make 2 flaps, 3 millimeter flaps, because I want to make 1 millimeter sclerotomies. And then this needle, now I have shifted to Gore-Tex. This was a little early, and this is 90 Prolene. So this 26 gauge needle comes behind, and when it comes over the iris, actually you need to tap this complex down, put viscoelastic and lift up the iris so that the second pass comes over the bag complex. The first one was through the bag, and so a loop will catch it, and the other side also you can, don't tighten or knot the knot first, 1 knot, both make slip knots and tighten it according to the centration of the lens and then complete it. This is again minimal manipulation. Question can be, why don't you just remove the whole thing and do a scleral fixation? Well, fine. But this is with minimal manipulation, this can also be done. So my last thing is, Somshila showed iris claw and nothing wrong with iris claw. This is one iris claw which was on the retina. So iris claws can also dislocate and go on to the retina, and retina person happily brings it up. So I don't believe in iris claws, so I do only scleral fixation. So I wanted to get this thing out. So he brought it up. So see, please see this coming up. And then one claw came up and the other claw is coming up. And he is pushing this one and coming inside. So there is a little pupil peeking, if you see. And then I am called, so I make a 6 millimeter scleral tunnel and then enter and identify this one. He said, IOL is there, you pull out the arrow. Now I realize that when I move the IOL, the pupil is also moving. So this iris claw has been clawed back again. See, this is what has happened. So iris claws are always waiting to see iris somewhere and to catch the iris and claw it. So when he brings it also, it was staying there. And for remembering that the iris is still there, it's going and clawing itself into the iris again. So this got clawed in, so it was just at the edge of the pupil. So I just cut the snipped the iris off and took it out. Other way is to snip off one claw. cut off one claw and then it becomes free, or you can just use both hands and then open it up and then snip out. That's all more difficult. The cornea is bad here, so we don't want too much of manipulation inside. And if this is enclaved here, I would not do this, otherwise you will get a large hole on the iris. Because it was enclaved when it was coming out through at the edge alone, I just snipped off the iris and took it out, and there comes the iris claw. Still won't leave iris, see, still holding on to the iris. So iris claws, as Somshila said, it will hold on to the iris very well. If you have not enclaved well, then it will drop like this. So make sure you enclave well. Then the next horror show is that I find that there is posterior capsule 360 degrees under the iris. So in panic situations like PCR and all, so you just show in some IOL, see, and then I place, while talking about this is going. This IOL was placed on the anterior capsule margin, but then when I held this is again going down. So pupil expansion and pupil dilatation visualization when you are doing all this is very, very important. So when I put the iris hooks, I identified that this haptic has gone underneath the capsular rim. So again, visualization very important, retracted it back and then lifted it over the anterior capsule and place it over 360 degree, there is anterior capsule rim. And then that is placed into the sulcus and the second haptic is dialed in and it is placed in position. We need to tap it and see whether it is bouncing back into position. Sulcus, sometimes sulcus may be little different in size and orientation, you may have to change. So now it is very well stable and this is centered. Thank you very much.
Thank you very much, Meenu. So questions for Meenu? Yes, Dr. Professor Madi, yes, please. Oh, you need to go? Oh, surely, why not? Please, please. Any questions for Meenu?
There are different ways of doing handling all these cases, but these are some ways you can get away with minimal manipulation. Secondarily, when you go inside, it's better you don't manipulate too much if you can get away with the
Meenu, about the safest way to do a secondary implant. Again, because the safety is something that is debatable, but right from the iris claw, where the possibility is, as you said, the disenclavation can occur at time, to the fixation, the secondary IOL fixation with sutures, where again fraying of the sutures at any point of time. And third, the use of Gore-Tex. So the use of Gore-Tex, how much have you inculcated in your practice? Because Gore-Tex is one suture that will last a lifetime.
So now if I have to suture a back complex or a secondary IOL, I'll use only Gore-Tex. But my use of that has come down to a very minimal thing, just like this case with the CTR and a lens in the back and you have to fix it. Or an aniridia IOL if you want to suture and fix it. These are the two situations I'll use a Gore-Tex or a suture. All the other cases I'll use, I'll remove the whole thing and do a glued IOL.
I think Gore-Tex is a little overhyped. You can use ninoprolene. See, the paper about prolene sutures getting frayed was on tenoprolene. Ninoprolene stays for lifetime. Gore-Tex is a little bit of hype. It's a little bit, and it's very difficult to handle also. The suture is a little difficult to handle.
So
she might tell you. She might tell you how to handle Gore-Tex.
Yes.
So Sunfaik is a different surgeon. Okay.
But I think
she will teach all of us. Yeah.
Oh yeah.
It's important, Professor Chi, if you can tell us how to handle the Gore-Tex, because when you're handling Gore-Tex for the first time, it can be really difficult. It can be very messy, and you can really think that why did I do it at all? Because of the thickness of the material, the stiffness of the material, which we are not used to when we are handling 9-0 or 10-0.
Escape from full screen. How do I escape from the full screen?
Any other questions we have? Yes, please. Yes, please. No, we really want everyone to participate, because we have kept the talk small so that the participation can be more. There are places in the front. You can please come, sir. Sir, you can come to the front row, sir. There are places in the front. Yes, please.
Sir, in this case, because it was closer to the pupillary margin, we just snipped off the iris while removing the iris claw. But routinely, what is the method of disengaging an iris claw lens from the iris?
Okay. Meenu,
As I told you, we can do it in two ways. One is to cut one of the claws. Just like with your banana scissors, or if you have a IOL cutter, you can cut one of the claws, and then there is a lot of gap, and it can easily come out of your enclaved area. Other thing is to try to manually pull. That is very technically very much difficult. And if it is only a very minimal area which is enclaved, and there might be lot of tissue loss and fibrosis and all those, you can make a small nick on the iris. It will act like a PI if it is beyond mid periphery. But if it is a large area which is enclaved, and if you cut through, it will become like a large iris hole.
So where do you cut the claw actually? If we cut the claw, then the iris claw cannot be used again to.
No, you're not planning to use the iris claw again. You have a backup of another IOL, and if you're explanting an iris claw, that iris claw is gone. Don't reuse that iris claw lens.
Sometimes while implanting the iris claw, a beginner surgeon might implant it closer to the pupillary margin than how much it has to be going away towards the periphery. In such situations, we might have to disengage the iris claw.
These are the ways I know. Yeah.
Okay, I'll answer this question, Minu, because we have an experience of the phakic IOL, the iris clip ones, the artisan as well, where you have the crystalline lens below. So you have to be we have to be very careful. So I'll just tell you one or two small tricks when implanting the iris claw. The first thing is the iris claw has to go in seamlessly without any pressure. Here, of course, it's a aphakic eye, so you have a very large chamber. So placing it in and having the incision a little larger than the optic size. So it goes in, you rotate it, okay? And then the special enclavation forceps is very important because it has a curvature to it. If you don't have that forceps, it can be very difficult and you will not get the right plane for the lens to go in. So that's point number 2. Point number 3 is when the lens has gone into place, then you have to predetermine from where the inclavation spatula will go in. Now the inclavation spatula is also something that is quite important, and it does not have a rough edge. It just has to enclavate on the clip of the claw. Now that has to be done as a different port than the port of your IA. If you want, you have to do an IA. So that port has to be different, and that port has to be right from the side. Means, say you're operating on a right eye, then it has to be, one has to be at 2 o'clock, the other has to be at 11 o'clock to 10 o'clock. Okay, so that spatula has to go in straight and then enclavate. Okay, so these are a few tricks. Now, when you're disenclavating, then again, it is again very simple. The pupil, you have dilated it. The pupil is, you have placed the forceps properly to grasp the optic, and then disenclavation is again by that same spatula, and the iris tissue just goes out. So it's not so difficult at all.
I'll answer your question. Actually, specifically, wanted to ask about disenclavation. How does the iris claw hold? There's a gap, you have enclavated. It's almost supposed you have parted it slightly and enclavated the iris. Now, if you are going to try to pull them apart, it's PMM, it's going to break. Change the plane, create a gap over there. So use a forceps or whatever to just hold one and push the other down. You create a gap, the iris will disenclavate.
Thank you so much.
Can I just make a comment on enclavation? What I do is I sit on top. After the IOL goes in, and you paste it horizontally across in the AC, you hold on to it, and then you dip one haptic behind the iris, and I have my actually side port which is at 90 degrees, and I just use you can use a viscoelastic cannula, and that part that you go to enclavate, right, you just tilt that up and you just press it in, and with the same port I then push the other part of the claw behind the iris, and then I tilt that up with the same viscoelastic cannula still there. I just enclavate it. So it's just one paracentesis with my other hand, with the other one just supporting the lens and tilting it so that when it comes forward, you can see where the claw is. Because in dark iris, it can be quite difficult, especially for Chinese, our iris is very thick. So I tilt the lens so I can actually see the relief that this is where it should be. And then I just enclavate it.
You don't have to change hands.
No, I don't change hands. It's the same. So one hand holds, and then it just tilts it up and down, and the other hand just enclavates. So it's one move actually. Yeah.
Thank you.
Okay.
Yeah, she's.
Okay.
Yes,
So
thank you very much, Professor Chi. So now we come to your lecture, and please feel free to ask Professor Chi any number of questions. She's again a teacher of teachers, and we are really glad that she loves India so much that she comes back again and again and again, and at times 3 or 4 times a year. Is that right, Professor Chi?
yes. So actually, I'm very sorry I didn't really prepare for this talk because it wasn't on my schedule, but I'm going to show you some video which is from another talk that I had. So you asked me to show how we can use the Gore-Tex suture, all right? So this is what we have, actually a needle that's very short and thick and really doesn't get across to, from one scleral point to another point of fixation. So, it's just conceptually, if you had a suture loaded on a modified CTR, how do you then get this part of the suture across to where you want to fix it? All right, so, well, if I had a lasso, I could just pull it across, right? So if you put the eye there now, you can see the whole idea. All right, so we enter the eye here, and then we extend the loop here and use this as a lasso, and you can see then if we were to pull, this is what we get. Okay, so it's a really very, very simple concept. So how do we create this suture snare? All right, so it's very simple. First thing is to thread. All right, you thread a 27 gauge needle. You can go through a TSK 30 gauge as well. All right, but these are the tips. All right, keep the suture dry. So I always dry my hands with gauze before I start doing this. Then you grasp the sutures with fingers. You don't use Kalman forceps, because if you do that, you'll crimp the suture, and that will flatten it and widen it. So it will not go through the bore of the needle. And you cut the tip on a slant so that it goes through easily. It's really very simple, and I'll just play this again. All right, so that's what I do. You can see I'm holding it with my fingers, checking whether it's through, and that's it. And then you catch it with a 1 cc syringe, and then you just bend it at whichever angle you wish to do it. Now, when you enter, I like to go in 2 mm posterior to limbus, and I like to go vertically so I know exactly where I am. If I do it at the slant parallel to iris, I may not be exactly 2 mm posterior when it comes in. So I extend that lasso, thread one end of a suture, okay? And you can do that for also fixing IOLs, one going behind, one going anterior. So there's a lot of uses. Okay, so this is a very cheap tool that everyone can create once you have the suture in your hand, and you don't have to use the needle. And so now you have a loop around. Okay, then you can tighten it, etc., etc. Okay, so I'm going to show you this case, which is a trauma case, all right? So whenever there's vitreous, the first thing to do is really address that, all right? Because surgery is not safe unless you clear that. So I'm going posteriorly because this lens is quite posteriorly positioned. Okay, after you have stained it, you can see exactly everything, and then you say goodbye to it. And then you can see I'm actually using a cotton bud there to indent, and that brings the nucleus up. Okay, now we have no vitreous there. I grasp it after spearing it with a 27 gauge needle with the bevel up, which you don't bend. And I have already my hooks, right? Some capsule hooks, some iris hooks. You can do it with capsule hooks. Sometimes it's not so easy to hook it up. It's easier to hook it up with the iris hook, so I have some iris hooks prepared. And then as you go along, you hook it up, support it to the anatomical position, and it's providing the counterforce. Now you know you practically have no zonules, right? So if you don't hook, you can actually provide the counterforce by gripping the edge of the capsulorhexis, but you must not use capsulorhexis forceps to hold. You need to use non-tools and not sharp forceps like this one from MST. So once you have capsule hooks that are hooking up to the equator of the bag supporting it, when you have no zonules, you have no support, you really need to insert a CTR early. So I do this after injecting viscoelastic just under the anterior capsule to ensure I don't trap cortex, all right? So I like to create space. So this is doing a trough and then a cross chop, okay? This is not a dense cataract, but in this way, when you do it, you don't really need to rotate unless it starts to rotate on itself, so you don't need to stress whatever minimal zonules that you have left, but this is a good technique for what I use for posterior polar cataracts. I use it for this. And you can see, actually, I remove the cortex without any effort, all right? So if you insert it into the right place after you put in the viscoelastic and push everything posterior to it, you don't have a problem with trapping cortex. Okay, I know a lot of people say put it in later, but if you don't put it in for a very severely subluxated lens, then you will end up catching the equator because in between there is no support, right, in the severe subluxation. So I preloaded the CTS with Gore-Tex and created the Hoffman pockets, and this is the lasso. Thread it, all right, pull it in, repeat it for the other side. And then we have 2 loops on that side. Of course, in this case here, because it is a severe subluxation, I will need another support opposite. So generally for 4 clock hours, I use one device. So 4 clock hours, I'll use the CTR. If it's 4 to 8 clock hours, I will use one CTS and one CTR. You don't have to pre-plan because sometimes you may lose more zonules and then you decide you need more support. So you can always add devices. And anything more than 8 clock hours like this, definitely you would need 2 points support. So you see, I've left them loose because when you pull them out of the Hoffman pockets, they will tighten on you. Okay, so you don't want to excessively pull it, especially if your rexis is a bit fragile, it's created by a femto capsulotomy, then you don't want to stress it. So you just do 2 throws, and then when you are doing bilateral fixation on both sides, it doesn't matter the tension. Okay, it matters if you're doing any one side fixation because you need to adjust the tension so that your RL is centered. Okay, thank you. Any questions for me?
Professor Chi,
Yes.
I only have to tell you, if I have a subluxation of my lens, I am going to you.
Sure, please book now to avoid disappointment.
I'll create one.
When I showed this, she taught me this technique, and I practiced it, and then did few cases with like this, creating. Then I showed it in some presentations, some talks. People found it little too many threads going here and there, and so many threads here. It is so difficult, doctor, and all. So please do practice this in a wet lab, because initially it looks like so many loops, so many threads. One you have to cut this and all those. So use one Gore-Tex suture, take it out into your wet lab, and get a goat's eye and do this once and then see. Then it is very easy. You will not entangle too much of sun. After that, it was this drying thing was very useful, and also not using the forceps. It's very. We will all use forceps, and it will flatten and it will never go inside, and it will just bend. That's what will happen.
Sorry. Thank you very much for being in such numbers for this course. And I've clicked photographs to tell Dr. Namrata Sharma that this course should go on. So, posterior capsular rent, and Professor Madi has shown a lot of scenarios, but this is something that we do definitely need to understand, and the IOL implantation. And that's when you are in a dilemma, you are in a fix, and the chill is down the spine. So this is one of the points of horror for every cataract surgeon when the posterior capsule has rented and you have promised a particular IOL for that patient. So what do? Do you change plans? Do you put that same IOL, or do you do something different? So let us look at this video, and it is a video in which it shows that there's a very large posterior capsular rent. And with this amount of posterior capsular rent, the first thing that has to be done is the high molecular weight viscoelastic that has to go in. And to partition off the large chunk of nucleus from the capsular end, and try and do a phacoemulsification under very low parameters if you can get through it. So this demands a lot of energy, a lot of patience, and a lot of viscoelastic that has to go in. The moment you see the tremulousness of the iris occurring, immediately stop. If you feel that vitreous has come in, immediately stop. Phaco has to come out, viscoelastic has to go in, and to do a vitrectomy before you do any amount of phacoemulsification, and that is the rule. Because if your phaco probe is sucking up the vitreous, so what is going to happen is the vitreous base is going to be sucked up, and then you have a problem. So in this case, very luckily, the cataract did not go down and it stayed. Now, you can see that when I have placed in this lens, now the lens, putting it in the sulcus is one of the safest, and then to capture it in the anterior capsule. Safest, stays strong and stable even if there is capsular dialysis. Now, the most important thing is this part of the final part, you must put in triamcinolone to see if any amount of vitreous is there in the anterior chamber, and to remove the vitreous by vitrectomy before you close this case. That should be, because please do not rely on your eye, on the microscope, on the brilliance of the microscope, because there can be a thread of vitreous which is going to the wound, and that, please remember, it's just not a thread of vitreous, it's pulling right from the vitreous base. So that we definitely need to remember. So now in this, is a PCR in a mature subluxated cataract, and what do we do for this particular case? So here we have the subluxation is very much there, and it is tough to get a neat and a round rhexis, whatever you need, whatever you require and desire. And here is one situation where I'm putting in the CTR right in the beginning, because I want first a stable bag, and then only my maneuvers can go in. So if there is a partial subluxation, a CTR, as Shubhan just said, has to come in as soon as you need. After the CTR, I still am not very, very sure that my bag is going to be in place. So I put in these iris hooks to support the bag. The capsular hooks would have been better at this stage, but for the purpose of saving a little bit of finances for the patient, we put in this iris hooks. Though, if it requires, definitely put in the capsular hooks. Here again, trouble is there because it is a small rhexis, it's a hard cataract, and all the maneuvers have to be done such that you are able to do it without much of difficulty, without more of subluxation already. So here we are there, and now that's the last fragment that is coming out, and let me see, where are we? So removing the cortical matter, and then removing the iris hooks, and we already have this PC rupture. So I had intended to increase the size of the rhexis, but now I will not, because I'm not going to put it in the bag. So we'll put it in the sulcus, and once in the sulcus, because the CTR is there, so if the CTR is there, so you can be sure that at least that bag complex will be there, though the lens is in the sulcus. Again, placing in the triamcinolone and seeing whether there is any amount of vitreous. So now let us look again a very large PCR, and in this PCR again, so the PCR, when it occurs, you have to assess the amount of PCR that is there, and then take the decision what is to be done at that point of time. And if there is a requirement to change the type of lens that you have actually promised to the patient, it must be done. So as you can see that we have detected the PCR, and before pulling out the needle, you definitely need to put in the viscoelastic. But again, one point has to be kept in mind, that the amount of viscoelastic that you put in must not be so much that it prolapses the vitreous itself, or it goes into the vitreous, and then you have a larger PCR than you had initiated. So here again, it is important to put in the lens in the sulcus. So I'll go on to the next ones. Now here we have another different situation, everything very nice and rosy, and nearly singing a song, finishing my surgical list, and then what happens? So here when we are nearly at the finish line, there we have a PC rupture and right in the center. Now if it is right in the center, and if it is possible, do create a PCC, and that's a most important step where you have to put in a high molecular viscoelastic just to tamponade the PCR that has occurred, and then with the forceps you have to carve out a small PCC. If the posterior capsular excess is well carved out, this will never extend, and you can put a bulky lens also inside the capsular bag, and that will stay put, that will stay central. But again, the triamcinolone should be there at the end. Now, flax. Promise the patient, oh, you're going to go back to work next day, you can go back to Switzerland next day and things like that, and then you have a PCR in flax. So it is not only a trouble, it's a mental trouble, and the biggest trouble is how do you face the patient after the completion of the surgery. So even in flax, you can have a PCR despite all these things, and this is a time that I had this PCR, and now removing the amount of the cortical matter has to be very judicious. You have to be very careful that the PCR does not increase. Here I'm putting in viscoelastic as much as possible. At times you can do just a dry aspiration without placing in the irrigation at all, but here you can see that the PCR is behaving extremely well, very sweet of him. So, and it is on the side. So here, since it is on the side, so here again, but this can enlarge. So just don't think that it is on the side. So we just place an intraocular lens, because the moment there's fluctuation of the anterior chamber depth, it can just rip apart. So it's best if it can be converted. You just have to convert it into a PCC, eccentric here, but once it is converted, then you have again a stable bag where you can place in the lens right inside the bag. And of course, creating a little bit of a partition with high molecular viscoelastic to tamponade that amount of PCR. So here again, we can place very safely an intraocular lens, a single piece intraocular lens in the bag. And once placed, it usually stays very central, and if you don't have vitreous in the anterior chamber, then it can stay put as well. So it's important again to place the haptics such that you do not engage the PCR openings at any time. So I'm going to, I'll skip this one for lack of time. So I'm going to show you this, the rest two videos are very small. Here we had a PPC, that's a posterior polar cataract, and you can see that, and you can see that that it's the typical hammock sign that you have in a PCC, and it has enlarged. Now what do we do? So the first thing is with a transverse rupture, the safest would be, of course, to put it in the sulcus, a 3-piece lens in the sulcus, capture it, and that's fine. But if you have a situation where the vitreous has not come in, and in many PPCs, the vitreous will not just flood in because they are formed vitreous, and usually in younger patients, and the cataract is also not very thick, then you have the ability that you can place in high molecular weight viscoelastic to tamponade even this PPC, the PCR, and then place the intraocular lens, landing it on the iris. This is something that Professor Chi has taught me. So the landing has to be on the iris, never first inside the bag, and then curving it down and creating a pivot so that under visualization, it goes into that space between the anterior chamber, the anterior capsule, and the ruptured posterior capsule. Similarly, this side as well, and under total visualization, if this can be done, if this maneuver can be done, then do. Otherwise, if it cannot be done, if there's vitreous in the anterior chamber, the bag has actually collapsed. So there you really will not be able to place it, so do not attempt it. So this is a situation where you can do either ways, but this way is also possible. So the last of my videos is an eccentric longitudinal rip. That the other one was very symmetrical. You had large pockets on both the sides, and the hammock was absolutely transverse. So it's quite good to land it on the pupil, on the iris, and then place it in. But here in this situation, we have an eccentric rupture. Can you see that eccentric rupture? And I'm placing in viscoelastic, and that is a large eccentric rupture right on that. But again, the vitreous has not prolapsed, so I'm placing in high molecular viscoelastic in between the ruptured posterior capsule and the anterior capsule, and then landing it there again on the iris. And this time it has to come into that position where you can actually wield in the haptic into that hammock, that space between the anterior capsule and the ruptured posterior capsule, very judiciously, keep it there, and again pivot it, fold the haptic over, and here of course the quality of the haptic optic junction has to be excellent, otherwise you might actually not be able to maneuver it. So these things are absolutely doable, but absolutely on case-to-case basis, and of course to be very judicious that there's no vitreous in the anterior chamber. Trifocal with PCR, shall I quickly show this? I don't know how much time do we have?
You have all the time.
Acha. So anyway, trifocal with PCR again. So 57 seconds. We might as well show same way. Now in these cases, should you implant or should you not implant? A trifocal, obviously with all the complication of tilt and everything, and obviously a little bit of decentration, the drop in quality, the drop in contrast sensitivity, everything can be a possibility. But yes, here of course again that same technique I did apply. I placed in this trifocal. The patient in the first eye had a trifocal. I said that I told the patient on the table that we have a problem, but we are going to do the best as of now. Patient obviously was a little scared, and when we usually show our surgeries to the patient party who is waiting outside in the hall, and obviously they came and said, "Doctor, you took too much time this time," and all. So we explained that this is the situation. We have placed the trifocal, but the quality of vision is not going to be as good. So I think in such cases, it's very important to be honest and truthful, and also to tell that if you're at the end of 3 months and 6 months, if you're not satisfied with the vision that you have, there are possibilities that we can exchange the lens as well. Usually, the patient subscribes to the idea, yes, I'm not seeing well, yes, right eye and left eye. Okay, doctor, after 3 months, fine, yes, you said so, okay. So, you know, it's very important to be transparent at these stages as well as to be judicious. So, these are the parts of the horrors that we face every day. Thank you very much. Any quick questions? I'll, yes, please. Yeah, so yes, it is very important that it has to be removed and not too much must be placed. Viscoat is something that I use, Helon is something that I use, Helon GV is also something that I use. But with Helon and Helon GV, it comes out in a bolus, whereas Viscoat will not come out in a bolus, and thereby you have to remove those strands of viscoelastic. When you have placed the lens in, when the anterior chamber is stable, you have to go on removing it. And these are points where you have to be sure that you're not also letting the vitreous prolapse again. because if you're removing the viscoelastic and the vitreous is coming up again you have to go in with the cutter, do a vitrectomy so that the vitreous is not there in the anterior chamber.
Sometimes the lens flips when you put this multi-piece lens.
Yeah.
Okay?
Yes. That's a very good question. See, again, injecting a multi-piece lens, once it is in the nozzle of the cartridge, you have to see how the fold of the haptic is. If the haptic is folded this way, then it just goes in and clockwise you can rotate. But at times it will be folded on the other way. So there you have to reverse the nozzle. The nozzle has to be reversed by the twist of your hand, and then the unfolding should always be so that clockwise you can rotate.
Thank you.
Yes. Yeah, Santosh, we always have a monofocal lens as a backup, and we have here in this particular case, if I could not place it in the bag, I would definitely have a monofocal to place in the sulcus. However, the other technique is you can place a single piece lens in the sulcus, but you have to capture it in the with the anterior capsule. If you can do that, then that lens complex is stable, though ideally it should be in the bag. Yes.
What did you tell the flax PCR patient?
Flax
PCR.
Flax PCR?
What did you tell the patient after the surgery?
I said that we are not going to charge you less. We have spent more of sweat.
Knowing Partho, you said, yes, I spent more time, so more money.
So in continuation to the previous question, you said the patient already had a multifocal in the other
First
eye.
eye, yes.
So how did you count, if you would have put up monofocal, how
Yes.
would you counsel the patient post-operatively?
Yeah. So again, here again, I'll be very not philosophical at all, but practical, that you need to tell the patient that things have not gone on well as was planned, and therefore for the best interest of the eye and for you, we have done a change of plan, because our patients are under topical anesthesia. At that point of time itself, without scaring the patient, we tell them that this is going to take a longer time. We might have to, even when I have to ask my VR surgeon to take over with a lens drop and things like that, we say that this is going to take more time. 2 surgeries will be required. So again, it's in the best interest of the eye. So the underlying statement should be, we are doing our best for your condition. It is not exactly what we planned, but these things happen rarely. These things have to be told and explained to the patient. And that, over the long years, I think all of us have learned the same way. So it's best to be very transparent. Yes?
Sir, then would you exchange the multifocal in the other eye later?
No.
No, that again is up to the situation. Again, let me tell you, the neuroadaptation, the mentality of the patient, the understanding of the patient is all very important. So usually a patient will not insist that, no doctor, you just take off this lens, unless it is really giving some trouble after 6 months or so.
Partha, actually you could do a
Yes.
reverse optic capture.
Yes.
If you had a PCR
Yes.
and you are putting in a trifocal lens.
Yes.
As long as your CCC is correct size and is centered, you
Yes.
can always do that.
Okay,
Absolutely,
so
yes.
just to answer your question, 2 aspects. One was the patient handling, other was the multifocal. I think it's always best to, whenever we're talking to anybody, it's better to always talk of their interest than our interest. Then in your interest, for your good, and that's a fact. We're just being honest. And I would have done it in my mother's eye, in my father's eye, the same thing. I think they relate very well to that. Okay, that's one thing. Second, multifocal, one-eyed patients I have done, they are very happy. So, having a multifocal in one eye and a monofocal in the other eye, with one having only distance vision and the other having multifocality is no bar. There is no problem at all. They enjoy the multifocality still. Okay, so you tell them that, see, the idea is, I have sometimes patients who have had a monofocal in one eye and want a multifocal in the other eye. So what do you tell them? See, for distance, you'll be using both eyes. For near, using one eye. You want to use both eyes? I'll give you glasses for the other eye.
I think now we have Gaurav.
Yeah, please, sorry.
Gaurav has to show, and I think we'll have to finish also. So, Gaurav, please. You can.
Hey, who's left? Is this? नहीं, गौरव तुम्हारे दो फोन है क्या? Sunfike, this is your phone? Your phone? I was wondering, no claimant.
Sure.
Hey, come.
We'll take it in front of the horror show.
The horrible people of the horror show.
Horrible people have horror show. Rightly quite.
And it was really enjoyable listening to all the videos that just came up. And I'll try to show you a couple of more horror shows. And we'll start with one situation where I was referred a patient who had been attempted for surgery, and the surgeon called in to say that she could not continue with the surgery because the lens suddenly kind of stood up. So I was wondering what it is, and then after evaluation and all, we found that there was a subluxated cataract, but instead of being subluxated backwards, it was kind of tilting forwards. So it was also a situation where she said that the moment she entered the chamber, that thing got worse. So we decided that once the eye settles down in a day or two, we'll go with the femto-assisted surgery. So the surgery had been aborted just after the first incision. So this is how it looked. You can see that the lens is tilting forward and the chamber is very shallow in this one area. So there was subluxation to one side. And why we decided to do a femto-assisted surgery is because that would give us better control. And in this situation, we were able to set the pupil size and everything correctly, and then fire the laser to get a perfect rhexis, because the manipulations of rhexis can sometimes lead to more subluxation, and you have to, just like Dr. Chi was showing that she had to take support of the hooks and everything in that patient. So here you can see that we are centering the rhexis into the perfect area, and then of course here also you have to make sure that the rhexis is perfectly placed in all planes, vertical and horizontal planes, otherwise you'll get a incomplete rhexis. And we are creating the correct offsets. We don't want to go very close to the capsule, so the posterior and anterior offsets have been corrected, and then you can go ahead with the firing of the laser. Now once that is done, things should be easier, but you are not always going to get a perfect rhexis. You have to check, and you should never pull on the that flap which is there. You have to tear it and see if there is no challenge in that. Now after this, adding viscoat to make sure that the anterior chamber is well maintained, inserting the capsular hooks. I try not to use the iris hooks here because iris hooks can cause pull on the tug on the capsular rim and break it, especially when you are in the movements. If you are doing a hard cataract, if you are chopping, sometimes you'll have a problem in doing the lateral separation. You'll end up breaking the rhexis. So the capsular hooks are always anchored at the equator of the bag, so there is little risk of causing a break of the capsular rhexis. Plus they also support, in these subluxated cataracts, they support the equator in a much more in an expanded way, so you can delay the insertion of your CTR till much later because your bag is supported in the equator at multiple points. So once that was done, then we had to take a call and reassess whether we were in a good situation to implant a lens, and also whether the bag would still subluxate anteriorly. So once we could get this cortex out, the lens was implanted after a CTR. Now once the CTR went in, the bag behaved very well. As you can see here, that once the bag, now I've actually removed the capsular hooks as well, and only 2 of them are left. This goes in nicely, and I look for the tilt of the lens and everything. It looks good. So we got away with this very, very peculiar kind of a subluxation. So while it was not a horror show, but at least it was a challenging situation because it looked really crazy on the slit lamp and also on the laser when you saw that anterior subluxation of the lens. Now this was horror show, but this is from a live surgery event in Calcutta where I was invited to perform, and I was told that we are going to keep challenging cases. I said, great, I enjoy doing challenging cases. So this was a Morgagnian cataract. When I was shown the patient was not dilated, and the pupil was small in the OPD, and later on the patient was dilated. When I went in to operate, this is actually the live feed from the live surgery. So this was a Morgagnian cataract. A toric lens had been planned, And after using these side ports and the main port, I put in trypan blue, and I was thinking that everything is going great. But see, what happened is that the trypan blue wouldn't come out after I put in the trypan blue. I tried to wash it out, but it just wouldn't come out. So you can see here that I'm now using a cutter that was basically vitreous. There was vitreous can get stained with trypan blue as well, as we all probably know once in a while that you have vitreous. So this was inferior vitreous presentation. So it was basically a subluxated Morgagnonian cataract. You can see there that this is vitreous which is kind of not getting washed out with PSS. So I remove it with a cutter and now inject Viscoat so that more vitreous doesn't come from that area, and now stabilize the globe and try to see if I can get away with the excess. You can see that the bag is moving, and this is all in live surgery. So it was not even something where I had the peace of mind, and now the excess will not happen, and the forceps did not really work that well, as always happens in these situations, in live surgery situations, and it's not holding. So I decided to go from the side port, and luckily all instrumentation was available, and I was happy because whatever I asked for was actually brought in, and they also made a retina surgeon stand by next to me saying that if you want to abort it, our retina surgeon will take over. So I said, let me try my luck first. And you can see here that we are fashioning a rexus somehow. Somewhere you have to go and cut it, sometimes you tear it. Finally, in this fibrotic kind of a capsule and a Morgagnonian cataract where there's a lot of loose cortex and the bag is very suspect, I managed to somehow get a rexus. Once that was done, then things become a little easier, except that this is a subluxate cataract. So now I'm going to try, and in Morgagnonian cataracts you do understand that there is no cortical support. So we will embed and try to make sure that the subluxation does not increase and the nucleus doesn't run away too far. So getting a good hold on it, I was able to crack it, and then a second crack and a third crack, and somehow managed to keep that nucleus from flying away. Also in these situations when the bag is subluxated and it's very free, it's very easy because this is a hard cataract and you have to go with higher settings. It's very easy for the capsular bag to come into the port of the phaco tip. So here now finally I'm rotating it in and getting that out. Now once that is done, I think it becomes much easier because now the danger part is over. Now I go back and inject a CTR. I'm trying to look whether there's a break. So I inject a CTR, but because I'm not very confident whether there's a PC rent or not, I've tied a small 10-0 suture to the eyelet of the CTR, so that just in case the CTR dislocates, just like it happened I think in one of Partha's cases where he wasn't sure and he had a PC rent. So the moment you have a PC rent and it enlarges, sometimes this CTR will dislocate into the vitreous and then your job becomes more tough. So you can see that now there is this 10-0 suture which is attached to the eyelet, and all we have to do at the end of surgery, so I like to call it as a suture secured CTR because it's like an insurance policy. Once your IOL is in, you can just pull on it and tug it and get it out once you're confident that everything's gone well. So this was, we could get away with this case nicely. So turned out not to be a Kolkata horror show. And now this was another patient where we had a femto-assisted cataract surgery. It was a hard brown cataract, and we did not know of previously existing subluxation. We had not documented anything, and it was planned with femto-LRIs. So a routine rexus and everything was done. Pupil was not very nicely large, but it was enough that we could operate. So once we started operating, we realized that there was some zonular laxity. And you can see that it's a hard cataract. At this point, when I was trying to rotate the nucleus, I did realize that there is a capsular laxity, and maybe not subluxated, but it was definitely a bag which was not very healthy. And once I got the brown cataract out, now this was the time when I wanted to go back and get the cortex. But now just watch what happens. As soon as the chamber is shallowing, you can see the whole PC bulge forward and come as close as possible to the cornea. So this tells you that there is good zonular laxity and the bag is not very healthy at all. So I'm now getting the cortex out. It's not tough. I'm able to do much of it. There is also a strand of some kind of a mucoid thing on the cornea which is disturbing the view here, but let that not distract you, please.
I'm not the chief instructor, but I'll deal with it.
So once this is done, you realize that I got a small dehiscence. So I've got the capsule here, and as I'm trying to do reflux, because I managed to catch the capsule. The chamber was getting very shallow over there, and I've done a reflux and let it go. And now I have a situation on my hands, because now even after doing the reflux, I can see that the bag is basically going to be very suspect. You can see a superior dehiscence over here. So I get the situation under control. Now I decide that I have to put in viscoelastic, make sure that this bag is distended. But before I can do anything, the bag starts moving down, and I push in viscoelastic and the bag is gone. It's like half of it is gone away inferiorly. So I quickly change the port. I try to now push viscoelastic from the other side port in the hope that I can salvage this bag.
Gaurav, we'll have to wind up.
You have to finish? Okay. So essentially, I was able to distend this bag and put in a CTR. Now putting the CTR itself was a challenge, because from whichever direction I would put the CTR would not, it would tend to increase the dehiscence. So in the interest of time, I'll just show you that finally we managed to put in the CTR in a very different from the side port, so that it went in the correct way without increasing the dehiscence. And once that was done, we were able to get the bag distended, get the cortex out, and finish the surgery. So I think we've run out of time. Otherwise, I would have shown you a couple of other things, but I think I'll stop here. And if there's any question, I'll be happy to answer that.
Thank you, Gaurav. I don't think we'll have time for questions, because the next session has to start.
Yeah.
We'll take questions outside the hall. Yeah. Thank you. Thank you. Thank you, everyone, for being here for the horror show.